Ask the expert. The role of biomarkers in stomach cancer.
My name's Sam Klempner. I'm a GI medical oncologist at Mass General in Boston.
Dr. Klempner, let's start with the basics. What is a biomarker?
A biomarker is a feature, usually of a patient or a tumor, that is associated with something. There's two broad categories. One is prognostic, which tells us about the biology or maybe how aggressive a tumor is. And then there are predictive biomarkers, which are biomarkers that tell us how likely a patient is to respond or benefit from a given drug. Within those categories, there are different types of biomarkers in terms of how they're tested. Some are proteins on the surface of tumor and immune cells. Some are mutations in genes in tumor cells. Some are features that can be picked up in the blood, but they all can be lumped into prognostic or predictive categories.
Why is it important for someone with stomach cancer to get biomarker testing?
We want everybody to know their biomarkers because it tells us, one, we might be able to give you better predictions about how you may do in terms of survival or outcomes with given therapies. And it also, even more importantly, will help us choose the best therapy. We really always want to pick right therapy for the right patient at the right time. And biomarkers are key tools that help us make those decisions.
We'll get into specific biomarkers in more detail later, but for now, can you tell us which biomarkers are most relevant to stomach and esophageal cancer and why?
There's really three main ones that we want everybody to know, and that's HER2, mismatch repair or microsatellite status, and PD-L1. And the reasons why is that some of these are prognostic, so they tell us how outcomes for patients like survival, and all of them are predictive. For example, HER2 predicts for benefit from HER2 targeted therapies. PD-L1 and mismatch repair or MSI predict for benefit from immune therapies. So they're critical for all of our patients to know, and also for all on the treatment team to know, to help pick the right treatment for every patient.
So there are specific treatments for specific biomarkers?
Yes, the intent of a biomarker is to help select a therapy. So most biomarkers are linked to a very specific drug or a very specific approach or class of drugs. For example, microsatellite instability high or mismatch repair deficient gastric cancers, that is linked to a high degree of response to anti-PD-1 or anti-PD-L1 checkpoint inhibitors. So biomarker linked to class of drug. Similarly, HER2 positive cancers are linked to response to trastuzumab or trastuzumab deruxtecan, which are the approved drugs for HER2 positive patients.
How do I know if I should be tested? And do I need to actually ask my doctor to test me?
Everybody should be tested. It's on all the guidelines across the world because it's associated with treatment that improves survival in many cases for our patients. And so there really isn't a good reason not to biomarker test. There are scenarios sometimes where a small biopsy might not have enough tissue, meaning actual tumor cells in the sample to do testing. And honestly, in those scenarios, biomarker testing is important enough that you should discuss with your team about repeating and having another biopsy so the biomarker testing can be done. Most of these biomarkers cannot be tested from the blood, but some of them can be, so that is often an alternate source of potential testing. It's always a good thing for patients to ask and be empowered and educated and say, what are my biomarker results? Because every once in a while we don't have a complete set and we need to make sure we're pushing to get the last remaining result, for example.
At what point should I get tested for biomarkers?
All patients should be tested probably honestly as soon as they're diagnosed and including at all stages of disease. In August of 2023, our national guidelines updated recommendations for biomarker testing that used to be restricted to stage 4 patients, now to move to stage 2, 3, 1 patients with stomach and esophagus cancers. because we're realizing that these biomarkers matter across all stages. So as soon as people are diagnosed, they should be tested, and they should be tested perhaps at multiple time points if there's been a very, very long interval between the last testing or a bunch of different therapies in between the treatments.
Why would I need to get tested again?
It's important because some biomarkers can change, and that change may influence how your treatment team and how your um, drugs may work. For example, HER2 is a biomarker that about 20% of patients are positive for in the beginning. But if they're treated with a drug that targets HER2, some patients, if you biopsy the tumor later on, it will no longer test positive for HER2. So the biomarker went from positive to negative, and we may use that information to guide our treatment choices.
What does a positive or negative result for a biomarker actually mean?
Positive and negative for a biomarker really mean it's there or it isn't there. For example, in HER2, we commonly use the term HER2 positive. That has on the back end of it a very specific definition, which has to do with the intensity of the protein expression or the presence of an amplification or too many copies of the gene. But we simplify that back end testing to positive or negative just so it's easier for us and easier for patients to think about.
What if there are no approved drugs for my biomarkers?
There are a lot of biomarkers that are linked to drugs that are currently investigational. So the testing for that biomarker doesn't gain access to an approved therapy because a therapy may not be approved yet. Some of these are linked to targets like Claudin 18.2, where the approval is expected imminently and was recently approved in Japan. And some of them are linked to drugs that are in clinical trials. Biomarker testing is increasingly the way we select patients for clinical trials because we want to identify the people where the drug is most likely to work, and information about the tumor or the immune system helps us make a good guess about whether the drug is more likely to work for any given patient. And so biomarker testing is exactly how we do that. And you have to ask your treating team whether they have access to clinical trials, whether there are nearby centers that have clinical trials, because those are the places that often have the earliest access to the biomarker testing. Sometimes it's even required as part of the clinical trial itself.
If I don't see any biomarkers on my pathology report, does that mean I don't have any? Or that biomarker testing wasn't done?
Oftentimes the biopsy result will come back that said, yes, there's a cancer, looks like a stomach cancer, but the biomarker testing may have been sent to another lab. It might be added on at a later date at the hospital or clinic where it was originally tested. And so really, I think step one is to ask your treatment team. They really should be able to tell you the results of your biomarkers and where it can be found in your medical record. Sometimes this comes as like a second pathology report if the biomarker test was sent out to a third party company. But it should exist either in the clinic notes summarizing the features of the tumor or within the pathology results for any given patient.
Earlier, you mentioned some key biomarkers in stomach cancer. I want to hear about each of those. Let's start with HER2. Why is HER2 important?
HER2 was one of the earliest biomarkers in stomach cancer. And really, it came about from the breast cancer world where HER2 had already been established as a biomarker. And it was a predictive biomarker, meaning that patients with HER2 positive tumors are more likely to benefit from therapies targeting HER2. What you need to know in the world of stomach cancer is that this is seen in about 1 out of 5 patients. So about 20% of patients will be HER2 positive. This is one of those biomarkers that can be tested a couple ways. So the typical way is by protein expression on tumor cells. And this is scored as 1, 2, or 3, or 0. And then by gene amplification by something called in situ hybridization. It can also be tested from DNA sequencing, either from the tissue or the blood, but the gold standard is protein or DNA copies, gene copies.
And what is the significance of PD-L1?
PD-L1 is one of the more recent biomarkers in stomach and esophagus cancer. PD-L1 is a protein that's seen on tumor and immune cells, and it's basically a mechanism that tumors use to slow down or impair the immune response to cancer because the tumor cells want to survive. PD-L1 is overexpressed, or patients are PD-L1 positive if their score is greater than or equal to 1. And this is a predictive biomarker, meaning that it's associated with a greater chance of response and benefit from immune checkpoint inhibitors. Most patients, up to 75 or 80% of all stomach cancers are PD-L1 positive. So many patients are candidates for immune therapies. Patients who are PD-L1 negative seem to have a lesser degree of benefit from immune checkpoint inhibitors. And we need other strategies for these patients, and it's a big area of investigation to try to understand how do we deal with the PD-L1 negative patients.
What should patients know about microsatellite instability status, MSI?
MSI is a problem that cancer cells have when they can't repair DNA in the normal way. So they build up a lot of mutations. And these mutations make tumors more likely to respond to immunotherapy. So MSI is both a prognostic biomarker and a predictive biomarker, meaning that MSI high patients, on average, survive longer than MSS patients or non-MSI high patients. And MSI high patients are also more likely to benefit from immune checkpoint inhibitors like PD-1 agents such as nivolumab or pembrolizumab. In terms of frequency, MSI is one of the less common biomarkers. In stage 4 patients, it's seen in about 3 to 5% of all gastric cancers. And in stage 1, 2, and 3 patients, it's seen in up to 20%, but more commonly 7 to 10% of patients. It's also interesting, MSI is associated with older age, so particularly the rates are even more common in people over 75 or 80.
So the more mutated the cells are, the better? Why is that?
Yes, MSI high patients have hundreds of mutations in the tumor cell, if not thousands of mutations. And in general, the more mutations in MSI high cancers, the greater the chance that some of those mutations are going to be recognized by the immune system as abnormal, and therefore the immune system will recognize the tumor as foreign and do its thing, which is eliminate foreign things like bacteria and viruses in tumors. So this is often measured by something called tumor mutation burden, but basically, MSI high cancers have lots of mutations, which makes it easier for the immune system to see them and recognize them.
I've been hearing about Claudin 18.2, and you mentioned it earlier. Why is Claudin 18.2 important?
Claudin 18.2 is one of the emerging biomarkers in stomach cancers. It's a protein on the surface of tumor cells, and it's expressed at a high level in about 40% of all stomach cancers, so a sizable portion of patients will be Claudin positive. Claudin 18.2 predicts for benefit from Claudin 18.2 directed therapies. We've already seen 2 big phase 3 trials that establish that targeting this biomarker selected patient improves survival when we give Claudin directed therapies. These drugs are antibodies that are added on top of chemotherapy in patients that express the biomarker. So we select people based on the protein.
Are there any other emerging biomarkers we should know about?
Yeah, there's a lot of emerging biomarkers for stomach cancer. And I think one of the messages of this is hope. I think we have a lot of hope for stomach and esophagus cancers over the coming years, that we can tease apart slices of the pie based on biomarkers so we can really hyper-select patients for the best therapies. Some of the ones that I'm interested in, beyond what we've talked about, are FGFR2b or an FGFR2. This is seen in a sizable portion of patients as well and might funnel them towards a specific FGFR2 therapies. EGFR, MET, these are probably some of the ones that are in later stage clinical trials, so might be coming to the clinic There's other immune biomarkers like DKK1, which might inform combination immune therapies. I'm not going to list them all, but really the message is that there's a lot of exciting biomarkers out there studying both the tumor cells and also the immune system so that we can get a full picture and pick the best therapy for the patients. But FGFR2, EGFR, MET are some of the most established emerging biomarkers.
Are there any other biomarkers you'd like to discuss?
I think it's important to understand that the list of biomarkers that we have that are standard is continuously expanding. And so at major academic centers, we will often look for many additional features of the tumor, often by DNA sequencing or other protein testing, because we want to understand as much as we can about the cancer, even if it's not yet linked to a given drug. And these features and understanding them early can help us identify future therapies, because we're always thinking like plan B and plan C and 2 steps ahead. And so the earlier we get kind of full packets of information, the better chances we can keep patients in mind for exciting future therapies. So beyond the standard biomarkers, which are HER2, MSI, and PD-L1, there are a lot of other ones that I think are worth testing even if they're not yet linked to a drugs.
What do you think is the most important message that viewers should come away with after watching this?
The most important message is really educate yourself and ask about biomarkers. If you ask, you have a much higher chance of being tested than if you never ask. And if you get tested, you have a much higher chance of having a full data set and being able to leverage that information to have the best possible survival. We really want to know as much as we can about patients' cancers to pick the best therapies. And patients are a critical part of this. The more they know, the better questions they ask, the better care they'll get. So just ask about biomarker testing. That's really the first step.